Hi, my name is Mark Creekmore, and I'm going to do an orientation for NAMI Advocacy. Um, First of all, let me tell you a little bit about my background. Um, I started in this field as a volunteer in college at an institution for delinquent boys in Upper New York State. I worked there as a volunteer and as a paid staff or 2 years. And then I came to the University of Michigan in the School of Social Work in a MSW program and a joint program in sociology and social work, PhD program. I graduated in 1977 and began working first as a general manager for the Ann Arbor Cooperative Society, but then I soon, after 3 years, joined a private nonprofit organization which was developing group homes for people with mental health conditions, intellectual and developmental disabilities, as the institutions in Michigan, those large institutions, were being closed. Those institutions no longer exist. They included people with mental health conditions, mental illness, serious and chronic mental illness as well. So we developed transitional group homes for people who were living in those institutions. I also worked because of my background in child welfare, worked in foster care and delinquency services, supervising three foster care programs in Wayne County, and developing a intensive probation program for youth who would have otherwise been sent to Maxi Boys training schools. Um, no, those institutions at that time now no longer exist, and most services to people with delinquency and mental health services are provided locally through the counties. Uh, the state still provides some direct services through a few remaining institutions, but not many. Um, I began working with NAMI in 2002 as I was being as a adjunct uh, professor at the School of Social Work and Psychology, and we developed a program for training police officers to de-escalate uh, people with mental health conditions who were in crisis. Those trained 75 officers over the course of 2 years, and that began my work with NAMI. Since then, I've been on the board of trustees, the board of directors, and of NAMI, and now I focus on advocacy. Let me talk a little bit about NAMI's general approach to advocacy. We define advocacy as community outreach, community education, and community action. The focus, of course, is on community. Most of the other NAMI programs focus on individual education, support, and advocacy, which is important, but different in terms of does not really often address the populations of people. Those populations include youth, um, people who are disabled by mental health conditions, sometimes seniors, also other groups that you'll see as we go through this orientation. Um, NAMI is the local county affiliate of NAMI Michigan and the national NAMI organization. We participate in state advocacy and national advocacy. The state advocacy is currently mostly with the Mental Health Association in Michigan, MHAM, and the Michigan Mental Health Clubhouses in Michigan. There are 40 some clubhouses in Michigan. We're very close to our local clubhouse, Fresh Start, and the clubhouse movement is very similar to NAMI as a grassroots organization. We also work with NAMI National on the national advocacy at the federal level, but our focus is mostly within Washtenaw County. Um, and the counties in Michigan provide most of the services um, through state funding, through state and federal funding for the people in the public sector. We focus particularly on gathering information and knowledge about mental health policies and their implementation. Let me unpack that a little bit. Information is just information about facts and figures, and that is developed into knowledge and points of view from the point of view of the people with lived experience, which is NAMI's focus. People with mental health lived experience, both the people who have mental health conditions and people who support them, their friends and friends as friends and family. Um, Policies also are important by county and local agencies. The policies really have to do with the rules by which they follow. But also those rules are implemented to various degrees. So we focus both on policies and their implementation. NAMI does this so that's our first orientation is information and knowledge about policies and implementations. We do this through developing relationships with policymakers, and those have two focuses. NAMI, we demonstrate that NAMI's point of view is important and essential in all considerations about policies and procedures. Well, the lived experience is give us our unique approach. That NAMI is not a paid professional service provider. We do not charge for our services. The second relationship that we focus on is the relationship of trust with the policymakers and with the people with lived experience, which we develop through interpersonal contact, showing up and working the relationship and what's current, talking about what's current with people with lived experience. So NAMI works in the public sector, but does not depend on public funds, even though we get some public funding for our work. NAMI advocates in 6 public sectors, which provide services to people with lived experience. Let me go through those a little bit. The first is the health sector. That includes hospitals, emergency departments, primary care physicians, including other kinds of things like physical therapy, physical medicine, dental care, and the rest. The second sector that we focus on are mental health condition, the mental health sector, largely provided by community mental health, which is the largest provider of mental health services to people with severe and chronic conditions, but also with nonprofits who are not essentially in the public sector, private pay, Catholic Social Services, Jewish Family Services, and those organizations. That's the mental health sector. The third sector is the justice sector, which includes police and courts. Many people with mental health conditions find themselves in some kind of relationship with either police or courts. Um, and so that is the third sector. The fourth sector is the education sector. Largely young people who are primarily the focus of emerging mental health conditions, that is from ages of 12 to 27, which is the primary time when chronic mental health conditions emerge. These include education programs, K through 12, colleges and universities, and skill training programs. The next section, the fifth sector, is the housing and basic needs sector. Housing takes a lot of priority, but also we're seeing more needs expressed through food supplement programs as those are cut. The last sector has to do with community agencies. Those include voluntary community organizations like churches. NAMI is a voluntary community organization. Community agencies and community service providers in like Ozone House, the and the Ypsilanti Student Advocacy Center are examples of those. So those are the 6 public sectors that we focus our advocacy efforts on. NAMI's strength is its grassroots because most of our education, support, and advocacy is done by people with lived experience who are unpaid. The words volunteer and professional have stereotypical implications, which sometimes confuse people. There's a great deal of overlap between them, but also core differences which are important. NAMI is mostly volunteer and unpaid, but our volunteers are carefully selected, trained, and supervised in some similar ways as paid professional workers. Most importantly, our knowledge about mental health and mental health systems is advanced through our lived experiences. Some of our volunteers have professional backgrounds, like myself, but most NAMI volunteers share some important characteristics most NAMI volunteers, however, share important characteristics with paid workers. So sometimes it's easy to overstate the differences, but the differences are there between paid volunteer work and about focusing on people with lived experience and professionals. NAMI works collaboratively with professionals and other grassroots and professional organizations. That's an important characteristic of NAMI's strength as being grassroots. We don't have the capacity to accomplish our advocacy goals alone, so we collaborate with other organizations. There are some limits and some boundaries to NAMI's advocacy. The first has to do with resources. Just like in the paid professional world, NAMI resources are scarce, but our resources are not so much material, money, but our scarce resources are human, the volunteers that we use. NAMI grows by word of mouth, so many of our NAMI volunteers act as missionaries, so to speak, and spreading the word about the importance of NAMI for mental health, people with mental health conditions. The current environment is another limitation and boundary for NAMI's advocacy. And that has to do with the hostility that exists around mental health services, especially now. The hostility, first of all, is structural, which occurs through stigma and the pervasive stigma and discrimination around mental health conditions. So we currently have to fight the perception that the people with mental health conditions are all in some way similar. They're not, there's quite a bit of diversity, and that diversity is important. And it's expressed, that diversity is expressed through one of our most important NAMI activities, which is storytelling, which we allow and encourage people to tell their stories about recovery from mental health conditions so that people understand that mental health is not a fixed and given problem, but can be improved, and one can recover from a mental health condition and live a very satisfying and useful life, especially for the chronic and serious people with chronic and serious mental health conditions. The second is not structural in our social world, that is current with the federal administration, which is hostile to acts of caring, which we consider to be a social good, especially when we help people with special needs or people who need some kind of understanding about the importance of equity. We've all heard a lot about equity and the hostility of the current federal administration to diversity, equity, and inclusion. But equity is a very important part of NAMI's approach because we try to encourage people to do acts of caring and engage in acts of caring as a social good. That's currently being under attack through its funding and the workforce cuts by the current federal administration. That has implications, long-term implications, because these systems which we developed over the last, in my career, since the 1970s, late 70s and 80s, are being systematically destroyed and will be need to be rebuilt in a new fashion, perhaps more efficiently, perhaps better. That's our challenge. Um, so what does NAMI currently do in advocacy? We have three approaches to advocacy, which I'd like to outline here. And those will change over time. So in 2027, we may have different approaches, but here are the three approaches we have now. The first is to document over time the effects of funding cuts and the access to services in terms of the actual harm to people who are dependent upon those services and who are physically and mentally disabled, as well as the harm resulting from the anxiety, which is a secondary trauma to these cuts. Many people confuse the attack on immigration in the United States with the attack on basic social services. And while they're related in some conceptual way, the people are fearful of speaking out and because of the retribution through law enforcement, the courts, other places. Though some of those are unfounded, but we're still dealing with the documenting of both the funding cuts and the fear of those funding cuts as a secondary trauma. The service cuts are happening in the sectors we focus on, the health sector through insurances, and which will have immediate effects on increase in demand and use for emergency departments, for example. The mental health sector, which we know is going to face cuts. The education sector through the existence of counselors and mental health programs in schools. The justice sector through police and courts, and the housing and basic services sector. Those are the five sectors that will face most of the cuts. The community sector, the voluntary associations, won't be so effective. And they will have to pick up some of this slack. Our second focus, besides documenting the effects of the federal budget cuts, our second focus is to promote housing and basic services for a generation of people with chronic mental health conditions who are currently depending on aging friends and relatives who may not participate in the services through the six public sectors. There's a large number of people living at home, depending on the social, emotional supports and the economic supports of their family and friends who are aging out. And this is a large and important group of people, which we're focusing on through a lot of our experience as providers of care, people with lived experience who provide care for people with chronic mental health conditions, but aren't necessarily involved in all of the public sectors we've identified above. So that's our second focus. And we're providing a number of meetings to develop some concepts of how those people can be helped as their supporters age out, and they need to be live independently. Those people with mental health conditions need to live independently of their current providers who are aging. Our final area is a general area, and it consists of collaborating and gathering information at various public meetings. This involves two things: showing up at public meetings in the six sectors, and also developing relationships with those people who participate in those sectors. Let me identify a few of the public meetings which we currently monitor on a regular basis. The first set of public meetings is with the Community Mental Health Agency in Washtenaw County, and that has to do with the mental health sector. They have three routine meetings. One is the general board meeting of the Mental Health Board, which is open to the public and published on Zoom, but you can attend personally. They also have a millage advisory committee. Washtenaw County is fortunate to have a millage, which the mental health is a mental health millage. which has an advisory committee, which makes decisions about how funds are spent. And the third meeting is the executive committee and the finance committee of the Community Mental Health Agency. So those are all three meetings that we monitor regularly in the community for community mental health. The second set of meetings has to do with the health sector, which involves the Washtenaw Health Initiative. That's a collaboration of the hospital organizations, primary care physicians, mental health agencies, police, and schools, which is a collaborating agency for health across the county. We attend those meetings and report back to our advocacy leaders about what's happening in the health sector. The third area is what's called continuity of care meetings. Those are for the housing sector, and those meetings have to do with the funding and the working of public housing in Washtenaw County, both the Ypsilanti and Ann Arbor Public Housing Commissions and the Avalon Housing, which is a large private nonprofit organization which provides housing to 600 to 700 people in the county, and also other housing funding of new housing projects. So it's called continuity of care. That's a HUD designation by the Housing and Urban Development, Federal Housing and Development Administration to oversee federal housing funds locally. The fourth group of meetings are the Washtenaw County Commission meetings, since most of the county agency for the public agencies funds go through the county commission. It's really important that we monitor and develop relationships with county commissioners. There's working sessions and general sessions of the commission. Those are very important. The fifth sector is the justice agencies. We participate in police diversion programs and education sessions of the diversion programs for police, both the county and the Ann Arbor Police Department, as well as the Ypsi Police Department. There are, I believe, 11 police agencies in Washtenaw County, which are independent of each other. And we try to keep track of the largest of those agencies. The second justice area are the court programs. There's a diversion program, mental health diversion program, which diverts people with mental health conditions from unnecessary jailing or prison. So we participate and gather information from justice agencies. Those are public meetings as well. There are community collaborations like Washtenaw Alive, which provides collaborative services for suicide prevention, and we attend those. We also work with state mental health policy organizations like the Mental Health Association in Michigan. So we provide information from those 7 public organizations through attending their meetings and through developing relationships with those groups. So just let me review this. Our specific advocacy activities in 2025 include the documentation of the effects of funding cuts, the first. The second is promotion of basic services for that generation of people with chronic mental health conditions who are currently depending on aging friends and relatives. And the third is a general area of attending and gathering information from across these 6 sectors through the attendance at public meetings. So that's a brief orientation of NAMI Washtenaws advocacy organizations, advocacy activities. We have Tuesday meetings, regular Tuesday meetings from 5 p.m., which will add your name to the list. We, as people come in and we orient them, we try to determine what their specific people's who are new to the advocacy, what their specific interests are and how advocacy can advance their interests and concerns. I hope this has been helpful. You can contact me at pmcreek@gmail.com. Otherwise, thanks for listening and hope to talk to you later. Thank you.